Welcome to another talk in the series Surgery for Undergraduates. Today we will discuss varicose veins. Varicose veins are enlarged, swollen and twisting veins of the lower limbs, often appearing blue or dark purple in color. Okay, these are the varicose veins in the legs here. They are swollen, enlarged, elongated, twisting, and at times also tortuous. Okay, these are the words that I use to describe varicose veins. They happen when faulty valves in the veins allow blood flow to flow in the wrong direction or to pool in the superficial veins. More than 23% of all adults are thought to be affected by varicose veins. To understand varicose veins, we have to understand the general anatomy and blood flow in the veins of the lower limb. The lower limb veins, there are two sets of veins. The deep venous system, okay, which is red and maroon in color, which is the femoral and the popliteal systems. And the superficial venous system consists of the long and short saphenous veins. In the lower limb, the deep veins contain multiple valves along its course, which direct the blood in one direction towards the heart, from the feet to the heart. And the superficial veins are connected to these deep veins by deep perforator veins which are present in the lower thigh, below the knee, and at the lower third of the leg. These veins are connected by deep perforatous veins which contain valves which direct the blood flow from the superficial to the deep veins. Okay, the blood flow is from the superficial into the deep and from the deep back to the heart. So this is the normal unidirectional flow of blood in the lower limbs. The deep veins propel the blood to the heart by the muscle contractions, especially of the calf and thigh. And these muscle contractions will compress this blood in the deep veins towards the heart, and this backflow is prevented by the valves that are present in them. In the diagram on this side here, it shows the superficial venous system which is involved in the varicose veins. It begins at the saphenofemoral junction in the groin, where the long saphenous vein, which drains the main part of the superficial part of the leg into the femoral vein. And at the junction at the saphenofemoral region here is a valve that prevents the backflow of blood from the femoral or deep system into the superficial system. Okay, this is known as the saphenofemoral junction, which is very important when you examine a patient with varicose vein. Another set of veins known as the short saphenous or small saphenous vein. Okay, and this is the this superficial veins here over the posterior part of the leg drains into the deep vein, the popliteal vein, which then continues as the femoral vein towards the heart. It is important, as I said, there are multiple communicating veins between the superficial and the deep veins, and these are located in the lower thigh, medial aspect of the lower thigh, below the knee, the upper aspect of the leg, and the lower third of the leg. These are known as the perforators, which connect the superficial to the deep veins and direct the blood flow from the superficial to the deep system and then finally towards the heart. Okay, what happens in varicose veins? Okay, this is a normal vein where the blood flow is in this direction and the backflow is prevented by these competent valves that are present throughout the length of the deep veins. For some reason, which we will discuss later, the veins become dilated and the valves become incompetent. As a result, instead of the blood going forwards, when the muscles relax, the blood tends to flow backwards and cause pooling of the blood in the superficial system. Okay, this one shows you the diagram showing you the deep vein. Okay, is blue in color, which directs the blood by muscle contraction towards the heart, and it is unidirectional as secured by the competent valves in these veins. These are the superficial veins, the saphenous and long and short saphenous system, which is connected to the deep veins by what we call perforator veins, or perforating veins, or deep perforators as they are called. And blood from the superficial system flows into the deep system, and this is secured by the presence of unidirectional valves. Varicose veins arise from incompetent valves, as I said, which permit the blood flow from the deep venous system to the superficial venous system. As I said, the normal flow is from the deep system to the superficial system, but in varicose veins, these valves are faulty. As a result, the blood flows, when the muscle contraction, the blood flows backwards from the deep to the superficial system. And as I mentioned just now in the diagram, these are the three important communication centers that must be addressed: saphenofemoral junction, saphenopopliteal junction, and perforating veins that communicate between the superficial and deep system. Okay, these are the three communicating systems between the superficial and deep system that must be addressed or looked for in varicose veins. And this backflow of this blood from the deep to the superficial system results in dilated veins in the legs, which appear as bulging, thin-walled, dilated veins, okay, which are known as varicose veins, as can be seen in this diagram here. This is the common site of the varicose veins. Okay, this diagram shows you the deep and superficial systems more clearly. Okay, this is the deep system, the popliteal-femoral vein that drains the blood from the foot right to the heart. Then this is the superficial system made up of the short and long saphenous vein, which ends at the saphenofemoral junction. Between connecting these two systems, the deep and the superficial system, are veins known as perforator veins or deep perforators. Okay, there are three sets of them: one in the lower thigh, medial aspect of the lower thigh, one below the knee here, and another set at the lower third of the ankle. Okay, these are the three sets of communicating or perforator veins that drain the blood from the superficial to the deep venous system in the leg. Faulty valves in the deep system and the communicating veins result in backflow of blood from the deep into the superficial system. As a result, the blood accumulates in the superficial system to result in dilated and tortuous veins, which are superficial and visible as varicose veins. Okay, veins, as I said, can be classified. Varicose veins can be classified into primary and secondary. 98% of the veins are primary, in which the cause is not known. The secondary causes of varicose veins include deep vein thrombosis, pelvic masses, example pregnancy, uterine fibroid and ovarian masses, and AV malformations, such as in the case of the Hippel-Trenone syndrome. 98% of the varicose veins are classified as primary. That is to say, the causes are not known. But the underlying causes that predispose the patient to varicose veins are twofold. First, the wall of the vein is stretched. And secondly, the valves in these veins are defective. That is, they are incompetent, allowing reverse flow of the blood in the veins. The potential risk factors in these patients include gender. Women are more affected than males. It may be that female hormones relax the veins, and this explains why patients on oral contraceptives and hormone replacement therapy at higher risk of developing varicose veins. Varicose veins are also genetically predisposed, as it runs higher in families. Obesity is another important cause which increases the risk of varicose veins. Age, the older the patient, the higher the risk of veins. Patients above the age of 50 have a higher risk of, much higher risk of developing varicose veins. Certain jobs that demand or require the patient to stand for long periods of time at work may have a higher chance of varicose veins. I've said pregnancy and other pelvic tumors also predispose the patient to a higher risk of developing varicose veins. Menopause patients, postmenopausal patients also have a higher risk of developing varicose veins. Okay, this picture shows you varicose veins, prominent, elongated, appear as bluish black, dilated veins superficially in the leg. Okay, here. This is a varicose vein here, or sometimes it's also known as varix. Okay. Again here, see the lower part from the knee down to the medial aspect of the leg. Prominent elongated veins which appear bluish greenish in color. These are the superficial veins of the venous system that get engorged with backflow of blood. There are some fast facts of varicose veins. Pregnant women are more susceptible to varicose veins than non-pregnant women. Symptoms can include aching of the legs, swollen ankles, and spider veins in the leg. And these people who are overweight, have an increased risk of varicose veins. Varicose veins, how do they come about? Veins have one-way valves so that the blood can travel in one direction, and usually is from the periphery, from the foot, down to the heart. If the walls of the veins become stretched and less flexible, elastic, the valves may get weaker. Okay, when the walls become stretched, so the valves become weaker. and become incompetent. A weakened valve can allow blood to leak backwards and eventually flow into the opposite direction, and when this occurs, blood can accumulate in the veins, which then become enlarged and swollen. So the backflow is from the deep to the superficial system, which is abnormal. The veins furthest from the heart are most often affected, such as the veins in the legs. This is because gravity makes it harder for the blood to flow back to the heart. Increased intra-abdominal pressure has the potential to cause varicose veins. These include pregnancy, constipation, pelvic tumors. Okay, this is a diagrammatic diagram to show you what happens, how varicose veins come about. These are the varicose veins here of the long saphenous system here. Okay, these are the varicose veins, and here you see the normal vein has got competent valves. The valves can stop the backflow, whereas in varicose veins, due to certain mechanisms, the valves become distended and the valves become incompetent, and this results in a backflow of blood and stasis of blood in the superficial system, and this is known as varices. The clinical features of varicose veins. Okay, varicose veins patients will typically present initially with cosmetic issues like dilated and unsightly veins visible in the legs, or the discoloration of the skin. Worsening varicose veins may then cause aching or itching over the area, and subsequent complications, if left untreated, can include skin changes, skin ulceration, thrombophlebitis, or bleeding, often presenting post-trauma. On examination, the varicosities will be present in the course of the long or great or short saphenous veins. They can also present with features of chronic venous insufficiency, such as ulceration, varicose eczema, or hemosiderin deposits. Now, what is restless leg syndrome? This is the uncontrollable urge to move your legs, usually because of uncomfortable sensation. It typically happens in the evenings or nighttime when you are sitting or lying down. And moving the limb eases the unpleasant feeling. Okay, this is the very frequent presentation of varicose veins, especially early varicose veins. It is known as restless leg syndrome, RLS. A word about saphenous varix. A saphenous varix is a dilatation of the saphenous vein at the saphenofemoral junction in the groin, where the long saphenous vein joins the femoral vein at the groin. It may display a cough impulse, which is commonly mistaken for a femoral hernia. Suspicion should be raised in any suspected femoral hernia if the patient has concurrent varicose veins in the rest of the limb. These can best be identified using duplex ultrasound and management via high saphenous ligation. Something about pregnancy and varicose vein. Women are more likely to develop varicose veins during their pregnancy than any other time in their lives. Pregnant women have much more blood in their body, and this places extra pressure on the circulatory system, including the venous system. In addition to this, changes in the hormone levels during pregnancy can lead to a relaxation of the blood vessel walls, and these lead to the risk of having varicose veins. As the uterus grows during pregnancy, there is more pressure on the veins in the mother's pelvic area. In the majority of cases, the varicose veins go away after the pregnancy is over. This is not always the case, and sometimes even if the varicose vein improve, there may be some left visible. So they do not completely disappear. In fact, some of them become worse after subsequent pregnancies that take place. The gold standard for varicose vein investigation is a duplex ultrasound, assessing the valve incompetence and the great or short saphenous veins and any perforators that may be present in the deep system. Deep venous incompetence, occlusion especially to deep vein thrombosis and stenosis must also be actively looked for in this duplex ultrasound. Varicose veins and concurrent DVT. In a patient with identified to have concurrent DVT, you cannot treat their superficial incompetence, as the venous blood will have no route back to the heart. Consequently, any patient with deep venous incompetence is typically offered a non-surgical management. So this picture shows you the stages of varicose vein. Here is a patient with normal legs, no varicose veins. Stage 1, you have reticular veins or spider veins seen on the leg, especially the lower leg. Stage 2, varicose veins or venous nodes develop. They become bigger and they appear as nodes. And these are the stage 2 varicose veins. Stage 3, where they develop chronic eczema over the lower leg. Besides the varicose veins, you also develop eczema and skin changes. And stage 4 is when varicose eczema or ulceration takes place, usually at the lower part of the lower third of the medial aspect of the leg. How do you prevent varicose veins? Reduce the risk of developing varicose veins. Get plenty of exercise, especially walking. Maintain a healthy diet. Avoid standing too long. Do not sit with legs crossed. Sit or sleep with your feet raised on a pillow or two. And anyone who has to stand for their job for long hours should try to move around at least once in 30 minutes. What are the investigations that can be done for varicose veins? Varicose veins are easily diagnosed by a physical examination, inspection, and palpation. Then this should be followed by some special tests, and the two important tests are the Trendelenburg test, which is also nowadays known as the tourniquet test, and Perthe's test. Following this, many of these tests are now becoming less and less used because we have better methods of detecting varicose veins, such as the Doppler test and the color duplex ultrasound scan. Doppler test ultrasound scan to check for the direction of flow in the veins. This can also give check for the blood clots or obstruction in the veins. Nowadays, with color duplex ultrasound, we have color images of the structure of veins, which helps to identify any abnormalities and can also help to measure the speed of flow. So any regurgitation or slowing down of the flow of blood can be detected by means of this color duplex ultrasound. I mentioned venogram here because in cases where you're unable to determine deep vein thrombosis, then venogram is the most reliable investigation, which may have to be done especially in patients who are planned for surgery. Complications of varicose veins. In the majority of cases, other than being cosmetically unacceptable and with mild aching sensation, most of them do not have any major complications. If they occur, they are usually bleeding from, especially at the lower part of the leg, due to increased venous pressure, and minor injuries can cause bleeding. Infection and thrombosis, known as thrombophlebitis, which is blood clots in the vein of the leg, which causes inflammation of the vein. It can cause chronic venous insufficiency, which is poor blood flow to the skin and affected areas of the leg. People with chronic venous insufficiency may develop varicose eczema and lipodermosclerosis, which is a hard and tightening of the skin over the lower leg. Then the other main complication is venous ulcers. Classically form around the ankles and are often preceded by a period of discoloration of the area. Okay, now let's look at the compression stocking working mechanism. The compression stockings help to squeeze the patient's legs and thereby improve the circulation of the blood flow from the foot to the heart. It is designed in such a way that the pressure in the stockings is graded. They work tight around the ankles and loose further up the leg. In this way, the compression stockings encourage blood flow properly upwards against the gravity and back towards the heart. Compression stockings may also help with the discomfort, pain and swelling experienced by the patient, but not sure whether it will stop the varicose veins from bursting or even prevent them, but definitely it will improve the symptoms of the patient. In some patients with varicose veins, application of compression stockings makes some people's skin dry and flaky. Now we come to the surgical treatment of varicose veins. First, the indications for surgery. Symptomatic, the patient must be symptomatic and with severe pain. Doesn't matter whether it is primary or recurrent varicose veins. So the symptomatic, first of all. Secondly, with lower limb skin changes such as pigmentation, eczema, which is thought to be due to chronic venous insufficiency. Thirdly, superficial vein thrombosis, which is usually characterized by the appearance of hard, painful veins. Okay, and these with the presence of suspected venous incompetence is another indication for surgery. The next indication is a venous ulcer, which is not healing, a non-healing venous ulcer. Again, in summary, pain, huge varicosities, repeated bleeding, and non-healing ulcers are the indications for surgery. And what are the treatment options available for varicose veins? Vein ligation, stripping, and avulsion is one of the most commonly used surgical treatments for varicose vein. This involves making an incision in the groin or popliteal fossa and identifying the responsible refluxing vein before tying it off and stripping the vein and it's away from the leg. Care must be taken because this stripping of these varicose veins can result in saphenous and sural nerve injury. Next treatment available is called foam sclerotherapy, which involves the injection of sclerosing agent, which is an irritating agent, directly into the varicose veins, causing an inflammatory response and subsequent fibrosis of the vein. This is done under ultrasound guidance to ensure the foam or the irritant does not enter the deep venous system and cause DVT. The third treatment available is the thermal ablation, which involves heating the vein from inside, either using radio frequency or laser catheters. This is also done under ultrasound guidance and is generally known as the endoscopic or endovascular ablation of varicose veins. So in summary, the surgical intervention will be endovascular ablation using laser or radio frequency, high ligation, which I will highlight what it is in a short while, stripping of the varicose vein, avulsion of the varicose vein, and injection of or ligation of the deep perforators in the leg. Okay, now I'll briefly tell you what high ligation and stripping is all about. Okay, this is the leg of the patient, showing you the superficial venous system and the SF junction here. So make an incision in the groin to expose the saphenofemoral junction as shown here, and identify the tributaries of this saphenofemoral vein, which is the external pudendal vein, superficial epigastric, superficial circumflex, and the medial accessory artery. Okay, so these are the common tributaries of the long subvenous vein just before it enters the femoral vein. So carefully identify this vein, this junction, and ligate off all these tributaries. At the same time, ligate the superficial long subvenous vein as close to the femoral vein as possible and transect the vein away from the femoral vein. Then a catheter is known as a vein stripper. Metallic vein stripper is then inserted into this long saphenous vein all the way right down to the ankle if possible, but in most cases at least until the popliteal region. And then you pull the stripper upwards from the incision here until the whole vein is stripped and removed from the leg. It can be similarly done to the superficial saphenous vein as well, introducing the stripper from the popliteal vein right down into the lateral part of the foot and stripping off the vein itself. Depends which system is predominantly the cause of the varicose veins. So this is known as high ligation of the saphenous vein and stripping of the long saphenous and together with the short saphenous vein. Sometimes if the varicosities are very big, then you may have to individually avulse the individual varicose veins, and that is known as avulsion. So this high ligation and stripping is one of the most common open surgical methods used for the treatment of very severe varicose veins with complications. Okay, this picture here shows you the metal stripper. Okay, it's got a T handle here for you to hold, and at the tip you can put various size strippers. Okay, the various sizes. Normally for the smaller veins you use the smaller stripper. The head of the stripper should be small, whereas the big veins you can use the big one. So you decide on the size dependent on the severity of the varicose veins. Once you have attached a head, you push the stripper down from the saphenous vein right down to the leg. Then at the tip where it is head is attached, and then Once it's in place, you can slowly apply some traction and pull the dilator until it brings along with it the long saphenous vein. Okay, this is known as the stripping of the saphenous vein. Then this is the segment of vein that is, you see this is the head here. So this is the segment of vein that comes along and you strip. Okay, this is the long saphenous vein that has been stripped off the leg and is exposed here. Now, in summary, what are the key points to take home from this lecture? First, varicose veins are tortuous, dilated segments of vein associated with valvular incompetence. That is, first, the definition of varicose veins. Secondly, the risk factors for varicose veins include prolonged standing, obesity, pregnancy, and positive family history. Thirdly, most patients will simply be a cosmetic issue. For most patients, it will simply be a cosmetic issue. However, can present with pain, aching sensation, swelling or itching, then some form of treatment will have to be given to the patient, either conservative or surgical. The gold standard investigation for varicose veins these days is duplex ultrasound. Management options in those that meet the criteria or those who need surgery include vein ligation and stripping, foam sclerotherapy, and thermal ablation. So these are the 5 takeaway points about varicose veins after this short lecture. Now I'll take you through some simple examination of varicose veins, highlighting the tourniquet test and the Perthe test. First, introduce yourself to the patient. Wash your hands before you touch the patient. Briefly explain to the patient what the examination involves, what you can expect from the examination, especially pain and discomfort. Expose the patient adequately by asking him to remove their bottom stock clothing, exposing the entire lower limb. If necessary, offer a chaperon to the patient. Then start by inspecting of the patient, but be prepared to be instructed to move on quickly to certain sections by the patient, by the examiner. Okay, this is what inspection involves. First, ask the patient to stand up and inspect from the back as well as from the front. Inspect the leg from the groin down to the foot. Look for signs associated with venous insufficiency. These include varicose eczema, hemosiderin staining, seen as brown patches, atrophy blanca, which are white patches with dark borders. Look for ulcerations, commonly located in the medial aspect around the ankle, also known as the gaiter area. Look for lipodermatosclerosis, lipodermatosclerosis, which is hardening of the skin distally and swelling of the calf. Look for varicosities present in the lower limb, inspecting the cause of both the long and short saphenous veins. The long saphenous vein on the medial side of the leg, running anteriorly to the medial malleolus, posterior to the medial condyle of the knee, before draining into the femoral vein in the femoral triangle in the groin. The short saphenous vein is in the posterior side of the leg, running posterior to the lateral malleolus, along the lateral border of the calcaneal tendon, before draining into the popliteal vein between the two heads of the gastrocnemius. After looking at these two major superficial veins of the leg, then inspect for scars indicating previous surgery. Also look for any obvious varicose veins that may be seen over the upper and lower leg, thigh and leg. Look for signs associated with arterial disease, assessing for potential suitability for compression therapy, which include loss of hair, nail thickening, surgical scars, and ischemic ulcers, especially checking the pressure points and between the toes. Okay, now we consider how a tourniquet test is done and how to interpret the tourniquet test. Okay, this is a diagram of the lower limb showing you the saphenofemoral junction and also the saphenopopliteal junction at the knee. Okay, so first, with the patient lying supine, elevate the affected leg and drain out all the blood from the superficial veins until they are collapsed. All the varicosities are collapsed. Okay, next, put the tourniquet in the upper thigh, and once it is tight enough, tight enough to compress effectively the superficial veins and block them. Then ask the patient to stand. With the tourniquet here, ask the patient to stand. When he stands, observe the filling of the long saphenous vein. If it fills from above, rapidly from above until the level of the tourniquet, then you can assume that the SF junction is incompetent. So the problem is primarily here. On the other hand, if this upper segment above the tourniquet is remains collapsed, and if the veins start filling from below the tourniquet, then you know the problem with the veins is below the tourniquet. Then it must be either at the saphenopopliteal junction, medial end of the thigh, where there are perforators, and also perforators in the upper and lower calf, lower leg. So repeat this Trendelenburg test with compressions at all these various levels, and then you will be able to diagnose the site of the incompetent perforators or incompetent valves. This is the tourniquet test to detect the site of incompetence, either at the saphenofemoral junction and the saphenopopliteal junction, or in the various deep perforators in the leg. Next, we come to Perthe test. This is to assess the functioning of the deep veins, whether the deep veins are patent. With the patient again supine, place the tourniquet around the thigh. Ask the patient to raise their heels off the ground 10 times. That means you try to squeeze the calf muscles to act as a pump to squeeze the deep veins. Look for collapse of the superficial veins. Okay, the veins, by the deep veins being pumped, it sucks the blood from the superficial veins, which then should collapse. If the superficial vein collapses, that indicates deep veins are functioning, as blood is returning through the deep vein system as usual. If, however, the superficial veins remain dilated or it becomes more dilated, that suggests there may be a problem with the deep vein system, whether it is obstructed or there may be incompetent valves in the deep vein system that prevents the blood from draining from the superficial system. Then it is considered Perthe test positive. So when Perthe test is positive, it suggests deep vein problem, either deep vein thrombosis or incompetent veins or incompetent perforators. Next, we come to the Doppler ultrasound scan, which has become the most important investigation for venous varicose veins today. Okay, it is very helpful to assess the site of venous incompetence, which is most commonly at the saphenofemoral junction and or at the saphenopopliteal junction. So placing the probe over these junctions will help to determine whether there is any incompetence and reflux of blood. It also is used to assess the patency of the deep venous system. Okay, the deep venous system can be blocked either to DVT or its function can be affected by incompetent valves and also the presence of perforators. So the Doppler ultrasound can help to assess these situations by assessing the deep venous patency system situation. It consists of a duplex ultrasound which incorporates the sound and image, produces not only the image, it also produces the sound of the blood flow. And nowadays we have this color Doppler ultrasound which can also allow you to measure the speed of the arterial and venous flow. It can also help you to diagnose peripheral vascular conditions, which are very important to exclude, especially if you are considering compression treatment or surgery for varicose veins. I hope this short talk on varicose veins will be of help to understanding this topic much better. Till I see you again in another series, thank you for being with me.